All right. Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. I'm Marina Salas, and I'll be the moderator for today's session. Our speakers are Andrea Bianchi and Callum Sutundar, and their seminar is entitled The Ethical Defensibility of Harm Reduction in Eating Disorders. Before I introduce today's speakers, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics website. The format of our seminar is a presentation by our speakers, followed by a facilitated discussion period. We would like to take a moment to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. We also stand in solidarity with the ongoing protests against racism and systemic discrimination. Now, it is my pleasure to introduce today's speakers. Andrea Bianchi is a bioethicist at the University Health Network, an assistant professor at the Dalla Lana School of Public Health, and an affiliate scientist at the Kite Research Institute at Toronto Rehab. She completed her PhD at the University of Waterloo, where her research considered the topic of dementia and sexual consent from an ethics perspective. One of Andrea's many areas of interest involves considering the ethical complexities and implications of various treatment options for persons with eating disorders. Callum Sutundar is an assistant professor in the Department of Psychiatry at the University of Toronto. She has a Master of Science degree from the Institute of Medical Science, where she studied clinical outcomes after inpatient treatment for anorexia nervosa. She has worked in the program for eating disorders at Toronto General Hospital. Currently, she works part-time in the perinatal mental health program at Sinai Health, and is in private practice where she sees patients in various stages of illness and treatment for eating disorders. Welcome to our speakers, and I'll now pass it along to you both to begin.
Thank you so much for the warm introduction, Marina, and thanks to the Joint Centre for hosting us and to everyone who's in the audience today. I hope that you enjoy our presentation, and we're looking forward to the discussion afterwards. I do want to mention that Catherine Stanley, who's on this slide, has also worked with us on this topic and contributed to the corresponding paper. She was unfortunately unable to be here today to present with us, but certainly want to acknowledge her work and efforts in relation to the topic. So in terms of today's presentation, we'll start off just by speaking about eating disorders generally, and also focus a little bit on SEAN, a specific type of anorexia nervosa that Callum will be speaking about. We'll talk about harm reduction in relation to people diagnosed with SEAN. We'll speak about some of the ethical considerations, and then we'll make some concluding remarks, and very much looking forward to the question and answer period and hearing your thoughts. So I'll pass it along to Callum to start us off.
Thank you. I'm going to start off with talking about what eating disorders are, and specifically the ones that we are speaking about is anorexia nervosa, but I do want to place it in the context of other eating disorders. So it's important to understand that eating disorders are mental illnesses where there are symptoms that are associated, they have a psychological impact, and they also have a physiological impact on the body. Typically, people who have eating disorders such as anorexia or bulimia are preoccupied with their food intake, with the amount of calories or the amount that they're getting in a day, or the types of food that they're eating. And they typically are preoccupied with body weight and with their body image. It's important when we're looking at eating disorders that we know that we're also often not dealing only with one disorder. Over half of people who have eating disorders such as anorexia or bulimia have a psychiatric comorbidity, and the most common comorbidities are depression and anxiety, post-traumatic stress disorder, as well as substance abuse. It's important to know that different types of eating disorders exist, and I'll talk more about that. Each has implications for treatment, and each also has implications for mortality. So if we talk about anorexia nervosa, what we're talking about is an illness where there is restriction of food intake that leads to significantly low body weight. And this can happen with or without purging symptoms. So if we think about a typical healthy body weight as being a BMI, body mass index, of between 20 and about 25, with anorexia, if you're below a BMI of about 18.5, then you're considered to have mild anorexia. Down to a BMI of less than about 11, then we're considering that people could be at imminent risk of death. When we're talking about purging symptoms, we're talking about symptoms such as vomiting or using laxatives. And this adds another degree of complexity and danger when it comes to health, because we're worried about electrolyte abnormalities and other types of illnesses that can cause arrhythmias and cause cardiac death. With anorexia, some of the psychological symptoms include intense fear of gaining weight or of becoming fat. And people tend to place a high value on weight and shape on their self-esteem. So typically when we talk with someone who doesn't have an eating disorder, they may say, these things have an impact on my self-esteem. Maybe my career, maybe my schooling, maybe my family, my relationships, my hobbies. These all form who I am as a person. When someone has an eating disorder, they may say, my weight and shape is the most important thing. I know the other things exist, but they're really not as important to me when it comes to forming my self-esteem or my self-identity. There's distorted perceptions and lack of recognition of seriousness of a low body weight. So what that means is when someone looks themselves in the mirror, they see something different than what another person sees. They may be very emaciated, but they see themselves as being fat. And they may say, I do understand that others are telling me that this is dangerous, that I can run into these complications or I can die, but they really can't appreciate or feel that they are in that situation, that they can be at risk. The lifetime prevalence of anorexia nervosa is about 0.9% in women and about 0.3% in men. And it's important to know that starvation can impact every organ system. Extreme starvation with purging can lead to a higher mortality. So what we're talking about is that being at a very, very low body weight can have an impact on the one thing that we're really worried about is cardiac function and arrhythmias. And if someone is very low weight and they're also purging, they're also vomiting, or they're also using laxatives, that can add another degree of stress that can lead to a higher death rate. And it's also important to note that this is the illness that has the highest death rate of any mental health disorder. The crude mortality rate is about 5% per decade. And so it's important to know that when we're looking at, even illnesses such as schizophrenia or mood disorder like depression, in fact, with anorexia, because of the added physical burden, the death rate is much higher. Typically, half of it comes from starvation, half of it comes from suicide. When someone has bulimia nervosa, psychologically, their experience and what they describe is very similar to anorexia. So a high degree of importance placed on weight and shape, a distorted body image, a fear of gaining weight. However, in this situation, their weight may be in the normal range or it may be in the high range. With bulimia, there are recurrent episodes of binge eating, meaning that people eat a large amount of food in a short period of time with a feeling of a loss of control that they can't stop once they've started. And then there are compensatory behaviors to try to prevent weight gain from binging. So this may come in the form of purging symptoms such as vomiting or using laxatives or other types of symptoms, or maybe non-purging. So if someone binges and then they fast for a long period of time afterwards, or like the rest of the day, then that would be considered a compensatory behavior. Or if they over-exercise as a way to not gain weight, that would be considered a compensatory behavior, and that would also be considered bulimia. The lifetime prevalence is higher, so 1.5% in women and 0.5% in men. Because with bulimia, although they have similar symptoms as anorexia, but their weight is in the normal or higher weight range, the mortality rate is actually lower because they don't have the added kind of dangerous symptom of being at a very low weight. It's important to note that there are other eating disorders as well. For example, there's binge eating disorder where people have recurrent episodes of binge eating, but there are no compensatory behaviors. Here, the lifetime prevalence is actually higher, so 3.5% in women and 2% of men. And there are other illnesses such as avoidant restrictive food intake disorder, rumination disorder, or what we call OSFED, other specified feeding and eating disorder, which in many cases are situations where a person has the symptoms of anorexia or bulimia, but perhaps the criteria in terms of severity or frequency of symptoms is not high enough to meet full criteria to meet those diagnoses. So what causes eating disorders? It's important to see this as being multidimensional, and there are biological, psychological, and social contributors. There is no one contributor, and we want to recognize that it can often be very complex. So there are predisposing factors, for example, genetics. So family and twin studies suggest that there's a very strong genetic component, over 50% heritability. There's also family history. So risk factors include a family history of obesity, of mood disorder, of substance abuse, and of obsessive compulsive disorder. There's also temperament. So perfectionism, obsessionality, excessive compliance, and low self-esteem, these can predispose one to developing eating disorder. Also adverse childhood experiences, such as childhood abuse or neglect, or early attachment and developmental difficulties. Also culture, so growing up female or being female, living in a culture with Western ideals of thinness can predispose one to developing eating disorder. And in fact, when we look at other cultures that become more Western or adopt Western ideals, then we also see the emergence of eating disorders in those cultures as well. There can be precipitating factors, such as disruptions of family homeostasis, changes in the family that are difficult to deal with. New environmental demands. So there's a bimodal age of onset, such as at the beginning of high school or at the beginning of university, where there are new environmental demands on a young person. There can be direct threats of loss of self-esteem or personal illness, such as becoming ill unexpectedly, such as surviving an assault. Also separations and losses. And then once a person develops an eating disorder, there are also perpetuating factors. So there are cognitive effects of starvation on the brain and of the illness. There are cognitive distortions that develop, such as seeing oneself differently when they look in the mirror, when they look at their body, such as black and white thinking or very rigid thinking that comes with the starvation and the effects of that on the brain. Also continuing personality traits such as perfectionism or obsessionality, and also the continued effects of living in a culture that values a thin ideal. So it's important to know that eating disorders don't discriminate based on gender. So if we looked at the previous numbers, we can see that they do affect men as well as women. It doesn't discriminate based on sex or race or ethnicity. We used to think back in the 70s, a long time ago, that this was an illness of people of high socioeconomic status. We now know that that is no longer true. But we do know that people can be at increased risk. So participating in certain sports. So having another predisposing factor is being exposed as a young child in the formative years to dieting culture or cultures and sports that really value a certain kind of body. And also, as I mentioned before, when you grow up in a Western society that glamorize perceptions of thinness. So here we're talking about people who have severe and enduring anorexia nervosa. This is characterized by having had anorexia for between 6 and 12 years or more. Typically what we're talking about in this situation is that we're talking about decades of illness. So the technical definition is 6 to 12 years or more, but we're often talking about people who may have developed this early on in their adolescence and may now be in their maybe 40s or 50s or older who continue to have the illness. It's important to note the severe psychosocial, occupational, and physical impairment that having severe and enduring anorexia can have on one person's life. So we talked about psychiatric comorbidity. These are harder to treat, and they also complicate the treatment of an eating disorder. So as an example, when a brain is impacted by starvation, one can't think as openly, is often more concrete, less able to think flexibly, less able to actually experience emotion. And we know that these are characteristics that help with psychotherapy. So when one's brain is starved and not able to think clearly, unable to feel, psychotherapy is going to be less effective. In addition, the medications that we use to treat some of the comorbidities, such as SSRIs that we use for depression or anxiety or PTSD, they're not effective if one isn't eating enough for them to be effective. So those treatments are less effective if one has an eating disorder, such as anorexia. And then they also complicate the treatment of someone who has anorexia. If one has PTSD and starvation leads to numbing of memories, thoughts, and emotions, then having treatment for anorexia could mean that these thoughts and emotions come up again and PTSD memories can resurface again. And so one needs to have a way to cope with and therapy to deal with these emotions and these memories as well. If one is very, very depressed, it can be very hard to feel motivated to want to get treatment for an eating disorder. So that complicates the treatment for eating disorder as well. I talked about the impact of starvation on cognition, an emotional experience. So emotions are numb and not as full when one is very starved. But also we want to think about the impact of starvation on capacity for treatment. When one's brain is starved, it's very hard to really acknowledge if someone can really understand the impact of their illness on their body, on their future, and then therefore, how capable are they to make treatment decisions? People who have severe and enduring anorexia may be underemployed or unemployed, because as you can imagine, if one's brain isn't working very well, or if one's day is very much filled with eating disorder symptoms, or they're too frail, have low energy, too tired to work, it's going to be hard to go to school or go to work. It can have an impact on social development and social isolation. So if one develops an eating disorder at an early age, teenage years where we're learning how to be social creatures and learning to figure out relationships, this can really derail one's social development. And you can be very isolated because a lot of what we do socially involves food. So you may remove yourself from events, any kind of interactions, which are pretty much all interactions that can involve food because of the fear of food. And then the physical comorbidities that people can go through will often require medical intervention or management, such as hospitalization. So if one is in liver failure, if one needs to be admitted to hospital because of cardiac failure, if one has osteoporosis or is at very risk of breaking bones, right? This is going to have an impact on what they can then do in their life. Being in hospital for a long period of time can have an impact on their life trajectory as well. When we think about recovery, we want to consider that people from eating disorders absolutely can fully recover from their illness. Recover from illness is more likely when it starts early on in one's illness trajectory, when one is younger. We usually can, we would say force a child into treatment or an adolescent into treatment that you wouldn't do so with an adult. And then also we want to consider that symptoms that are untreated can worsen over time. The thinking becomes more rigid, the behaviors become more entrenched. So it becomes much harder to treat over time. And so therefore, people who have severe and enduring anorexia, they encounter challenges when it comes to becoming entirely asymptomatic, so becoming fully recovered upon receiving treatment. Quality of life, as I described before, is also influenced. So people who have a longer duration of illness are less likely to recover, and they also suffer significant physical, social, and psychological sequelae as a result of being ill.
Thank you so much, Callum. So as Callum mentioned, people can absolutely recover from eating disorders of all kinds, but becoming completely asymptomatic will be more challenging for people with severe and enduring anorexia nervosa because of the nature of the disease and the symptoms associated with it. And so depending on the specific person that one is working with and the relevant context, there's going to be different types of treatments and different types of options that can ultimately be explored. So one option may be to encourage the person to change their mind, to try to convince them, encourage them to participate in treatment again with the goal of recovery. Maybe you'll provide information about what life could be like without symptoms, these sorts of things. When thinking about this kind of option, however, it is important to highlight that a very fine but important line exists when it comes to encouraging someone to change their mind and to be open to receiving certain types of treatment versus coercing someone to do so. And this very delicate line is one that people ought to be cognizant of. And it seems like this option is less likely to occur if someone has had anorexia nervosa for 20, 30, 40 years. Another option that could potentially be explored is to not provide treatment if the person doesn't want to or is just unable to strive for complete recovery in accordance with eating disorder program requirements. So many eating disorder programs, they'll have certain requirements that do need to be adhered to in order to receive access to that specific program. So for example, not allowing binging and purging to occur, not consuming diet foods, and these sorts of requirements are there for good reason in order to help people achieve a full recovery, but also because certain behaviors, certain eating disorder behaviors could potentially serve as triggers to other patients who are adhering to program requirements and are hoping to achieve a full symptom-free recovery. So this option ultimately suggests that if a person is just unwilling or unable to completely stop their behaviors, then perhaps they would be unable to participate in a specific program. Another option that could be explored in very specific types of circumstances would be to treat the person on an involuntary basis. But of course, this would only be a possible option to explore if a person were deemed incapable of consenting to a proposed treatment. And then a fourth option that could be considered may be that of palliative care. And by that, I mean only providing pain and symptom management, specifically in relation to the consequences experienced by having an eating disorder. So this option would not encompass any form of treatment with the goal of recovery of any kind. And we'll speak a little bit more about why what we are proposing and that of palliative care differs, but this option, it is oftentimes framed as controversial in the eating disorder domain. So if it turns out, so we've explored these four options, but if it turns out that a person with severe and enduring anorexia nervosa has all of these requirements, so firstly, does not want to and or is unable to achieve a recovery that is entirely symptom-free, and if they're capable of making their own treatment decisions, and if they want to live and improve their condition to achieve a certain kind of life or a certain quality of life, then perhaps one additional option could be considered. And the one that we are considering is what we're calling a harm reduction approach for people with severe and enduring anorexia. So harm reduction, many of you are probably familiar with this term. It's one that is used in discussions oftentimes when it comes to people with substance use disorders. And so it's defined as, and this definition is one that was provided by a wonderful colleague of mine, Danielle Buckman and Mary Jose Lynch, in a 2018 paper, which is that harm reduction is a philosophy and an approach to policy, programs, and practices that aim to reduce the health, social, economic harms associated with the use of psychoactive substances in people who are unwilling or unable to stop. And I would argue that harm reduction really became a more well-known term and a well-known philosophy, at least in part because of the opioid epidemic, where the idea is that instead of reprimanding people who use illicit drugs and demanding them to abstain from using, a harm reduction philosophy considers things like supervised injection sites, offering education about safe drug use, these other kinds of things, recognizing that the drug use would still continue. And so, as already mentioned, the purpose of harm reduction is not to completely extinguish the problematic health behavior completely or permanently. It really is to mitigate the possibility and the severity of the potential harms that may exist. So harm reduction approaches for people with eating disorders in general is really seldom considered, or at least seldom explicitly considered. One wonderful resource that does consider it is the Clinical Practice Guidelines for the British Columbia Continuum of Services. And in these guidelines, it suggested that a harm reduction approach could be beneficial for people with chronic eating disorders, where the goal is to improve one's quality of life. And similar to this, a very recent paper published in 2020 by Jaeger discusses this idea of compassionate witnessing, where Jaeger suggests that patients with SEAN are supported by validating their experiences, pursuing motivational interviewing, and providing resources and different options for their consideration. So these are resources that consider it to a certain extent, but we're being a little bit more explicit in terms of what we mean by this. So what we mean by a harm reduction approach for people with severe and enduring anorexia nervosa would look like the following. So it would include acknowledging and accepting that the person will continue to binge, to purge, to exercise, to engage in their eating disorder behavior or behaviors, and to try to mitigate the potential harms that may result from them. A harm reduction approach for this population, when employed, would not necessarily try to achieve full weight restoration, but rather it would focus on medical stability and an improved quality of life. And it would apply to both inpatients and outpatients, recognizing that many people living with eating disorders, including severe and enduring anorexia nervosa, are in the community. And so, similar to a lot of harm reduction approaches and the philosophy in general, the eating disorder behaviors would be openly discussed between the patient and team. So transparency would certainly be a part of this approach. So I'll pass it back over to Callum.
So practically speaking, based on a harm reduction approach, you might consider that a clinician and their patient with severe and enduring anorexia may agree that a person can, although you might not agree that person should, they can maintain a low BMI that comes with inherent risks to their health. And you may have an open discussion about what that BMI is that a person can accept and what are the inherent risks that may be associated with that low BMI. They might continue symptomatic behaviors while they might strategize how they can minimize risks. So you may speak openly about if a person has purging behaviors, maybe they would still get their electrolytes managed and looked at. Maybe they would take electrolyte supplementation by mouth to replenish and replace what they have purged to help them, because a long-term risk of that might be they could have an arrhythmia. This can minimize an arrhythmia, right? Or they may have, they may take vitamins as a way to replenish what they might not be getting, knowing that it's gonna play a minimal role, that they are still ill, there are still risks, but they can help them to not have some nutrient deficiencies. And they may also live insofar as they may undergo medical monitoring to make sure that they're medically stable. They may take vitamins or electrolytes. They may try their best to not allow their BMI to go underneath a mutually agreed upon weight, while also acknowledging the complexity of that. So a person may say, well, I can keep my BMI above a certain weight at which I can be more medically stable. Once they get to that BMI, that might, in their mind, drop. So that may be a continued negotiation between the clinician and the patient. And they may agree to consume a certain number of calories per day that can help them to maintain a certain quality of life. Maybe a certain number of qualities helps them to be able to have enough energy to leave their house, to be able to follow through with some social activities or hobbies. And you may have a discussion about what that can look like. We may also consider that resource intensive treatment. So we may consider treatments that require a limited resource, such as an inpatient admission, that this can be offered possibly for symptom interruption or respite, not only for recovery focused goals. A practical benefit of this is that a person who may be offered, for example, a short admission to a bed to try to have respite from their goals, they can have the opportunity to receive their respite from their behaviors without requiring a goal of sustained behavioral change. Respite from symptoms then might initiate a change, consideration of change-focused behaviors. If a person is on a bed having some respite from binging and purging, having some external containment to help them to feel less like they're on that cycle of binging and purging so they can think a little bit more clearly, that might then propel them to perhaps consider that they can have or tolerate further change as a way to further their quality of life. Or they may consider, maybe I'm ready for some further treatment that can help me with my quality of life.
Thank you. Okay, so as mentioned, I'll speak a little bit here about some of the differences that exist in relation to palliative care versus that of harm reduction for people with severe and enduring anorexia nervosa. And I believe that there may be a talk that actually is coming up at the Joint Center that considers palliative psychiatry more in depth. So stay tuned to that, but I'll say a little bit about it here based on how we understand palliative psychiatry to operate and speak a little bit about how it differs from our approach. And the differences may seem small, but I think they're important. So based on at least some understandings of palliative psychiatry, that the approach focuses on pain and symptom management and promoting a good quality of life. And all of these things could certainly fit into a harm reduction methodology as well. Recognizing oftentimes when it comes to palliative psychiatry, there may be some recognition that the treatment is futile. And so because of the futility and the focus, the sole focus of palliation, palliative psychiatry, it does not focus on, or at least significantly involve, modifying a person's disease at that time. And so alternatively, so we're thinking about palliative psychiatry, and then alternatively, our approach of harm reduction for people with SEAN, it does not or would not simply focus on pain and symptom management. It would focus, of course, on pain and symptom management insofar as some can be injured, as Callum has mentioned, as a consequence of eating disorder symptoms. But in addition to that, it's possible that a harm reduction approach may actually seek to modify a person's disease in order to ensure that they can continue to live or to achieve the kind of life that they want to achieve. So as Callum mentioned, it's possible that a person may want to continue to live with severe and enduring anorexia nervosa and want to participate in certain activities. Perhaps they want to be able to leave their home at times. And in order to do this, it may be the case that their disease has to be modified slightly or at certain times. And so I think each of the things that are done in order to enable a person to achieve their quality of life could be seen as modifying their disease to a certain extent. And then additionally, and perhaps most importantly, this harm reduction approach would be implemented both when a person is unable to achieve a symptom-free recovery. So this would be in line with palliative psychiatry, or at least some understandings of it. But it may also be considered when a person is at a point of their disease or in their disease trajectory and at a point in their life where they don't want to achieve an entirely symptom-free recovery, recognizing, of course, as Callum mentioned, that this desire could be motivated by many things, including their own disease and the consequences of their disease if they don't have full insight into it. So these are just some of the potential differences between these approaches. And I highlight this because there are also similarities. And so I think it's important to spell out some of the minor but important differences. And so when thinking about some of the ethics around harm reduction for people with severe and enduring anorexia nervosa, why might it be seen as ethically defensible, at least from some perspectives? And so I think that there's a couple of different reasons. I'll mention just a few primary ethics principles or perspectives here that may be worth reflecting upon when thinking about its defensibility. But I do want to highlight that this very short list of principles and perspectives is not necessarily exhaustive. So there's almost inevitably going to be other principles and ethics perspectives or theories that exist that could defend harm reduction for SEAN and also argue against it. So I'll just take the first one to start. So when thinking about autonomy, one common conception is this idea that people should be given the opportunity to make their own decisions when it comes to their quality of life and when it comes to their treatment plans. And I would argue that harm reduction at its core, it really does try to promote and to enable people to make autonomous decisions by allowing them to direct their own goals based on personal interests and perspectives and based on their life and life stages. One of the challenges, however, when thinking about autonomy and people with eating disorders is that specifically when it comes to people with severe and enduring anorexia nervosa, is that they might be in denial about the seriousness of their own illness. And in fact, this is part of the psychopathology of anorexia nervosa, which Callum knows much more about than myself, and as she mentioned. So the challenge in this kind of circumstance, and I'll speak about this in a moment, but the challenge really becomes whether a person with SEAN can in fact make an autonomous choice if they don't have adequate insight into their disease. I do want to note here, prior to delving into that I think it's important to differentiate between capacity and autonomy. And so while a person without any insight into their disease might be deemed incapable of making certain treatment decisions, it may still be the case that they could make or contribute to certain autonomous decisions. And I would argue that it really is up to us, to a certain extent at least, to enable their autonomy. And there's certain ways that I think we can do this that have been discussed in the literature. So one of these ways, one way to enable or promote autonomy might be to think about what a relational approach or what a shared decision-making model might look like. So perhaps people with SEAN that have lack of autonomy because of their disease could make decisions with the support of those around them, probably with those who know them quite well. And so when it comes to enabling autonomy, maybe this is one way that it could be done, but it also may be worth exploring whether a person is consistently expressing the same goals and the same desires, irrespective of the status of their disease. So if a person is consistently expressing the same goals, regardless of whether they are capable, incapable, in the worst parts of their disease, whether their weight has been restored to a certain extent, if they're expressing these same desires consistently, then perhaps this may be one way of determining if that desire is to some extent autonomous. And then additionally, I would encourage people who are working with people with SEAN to explore if anything can be done to optimize their autonomy, even for a short period of time. So would providing a person with treatment for a short period of time enable them to express their autonomous decision, even if they then slip back into their disease, and even if they start to, if their symptoms recur, perhaps having that opportunity to at least gain insight as to what their autonomous decision would be, that would be very valuable. And so when thinking about moving on to the second one, when thinking about virtue ethics, so here we're really thinking about the ethical defensibility of harm reduction through a virtue ethics lens, specifically when thinking about clinicians who are thinking about offering harm reduction options. And so to give a very brief overview, virtue ethics, and many of you on the line may already know this, but virtue ethics doesn't focus primarily on isolated acts, but a virtue ethics approach, it focuses on the character of the person acting in terms of when thinking about the ethical defensibility of an act. So is the person being honest? Are they being loyal? Are they being compassionate? Are they acting in accordance with certain virtues? So virtue ethics is really based on promoting virtuous character traits. So when we're thinking about virtue ethics and harm reduction in general, a few authors suggest that a character trait of compassion specifically might be that which motivates harm reduction workers and programs to be ethically defensible. And this is because compassion is seen as a virtuous character trait. So ultimately, insofar as harm reduction inherently involves being compassionate, which I would argue it does, then it would presumably be seen as defensible from a virtue ethics standpoint. When we're thinking about trust and trustworthiness, so it seems as though harm reduction might help clinicians demonstrate trustworthiness and build trust with people with severe and enduring anorexia nervosa. So many people with SEAN are stigmatized and are judged, and they are, and perhaps people with eating disorders more generally, but certainly this population, and Callum can speak more to this than I can, certainly that they're likely to encounter certain challenging experiences in the healthcare system. And some of that, which is documented in the literature at least, is because of clinicians failing to understand their diagnosis, perhaps providing them with insufficient suggestions that may undermine the complexity of severe and enduring anorexia nervosa. Some clinicians may consider this population to be challenging or non-compliant. And this could all lend itself to challenging experiences with the healthcare system, and it may influence some people with SEAN to not seek medical attention even when needed because of this lack of trust that exists. And so when thinking about the importance of trust, harm reduction is really inherently, or at its core, it's non-judgmental, and it aims to meet the patient where they're at. So harm reduction encourages practitioners to be willing to engage with patients irrespective of whether they're in crisis, whether they are experiencing acute episodes of acute illness. And it seems like this nature of harm reduction might make it such that people with SEAN are more likely to trust their clinicians and to seek care when needed. And looping back to one of the points that Callum just made, if a person with SEAN is at least willing to seek care when needed, then they may actually become aware of resources that exist in the community for them. Perhaps they may become open to receiving certain types of treatment. But if they are unwilling to seek any sort of help within the medical system, then this is certainly a problem. And finally, when we're speaking about providing benefit or preventing certain harms, and there are different arguments to be made around this, but it seems like harm reduction would actually support these conceptions of providing, and these principles of providing benefits and preventing harms, because it would decrease at least some of the most significant harms that would be experienced potentially by someone with SEAN if they seek no support whatsoever. And so because of the specific context and the specific diagnosis, it seems like harm reduction's ability to provide some benefit and some harm and prevent some harms to people make it such that it could be seen as defensible from this perspective. And so at the bottom of this slide, I just note that while harm reduction is certainly becoming a more, I would say, widespread philosophy to care, it certainly does encounter some pushback and criticism as well. And so some of these critiques are that harm reduction encourages people or allows people to remain stuck in their addiction cycle or to remain stuck in their eating disorder cycle. And because of that, it may be seen as indefensible. And also there's an idea that exists out there that harm reduction actually encourages people to engage in quote unquote bad behaviors. And so here we're thinking about eating disorder behaviors, or of course where harm reduction is typically used is when it comes to people with substance use disorders, and this idea that harm reduction encourages them or really allows them to engage in behaviors that are just objectively bad. And so these are challenges to harm reduction that we disagree with when proposing this because of the specific context and nature of the disease, but it's certainly worth noting that they exist. And so just being mindful of the time, I'll make just a couple of concluding remarks. So just wanting to highlight that a harm reduction approach, we are not suggesting that it's appropriate for every patient in every context. We are suggesting that a specific harm reduction approach might be suitable for some patients with severe and enduring anorexia nervosa who want to live and who want to maintain a certain quality of life and who are also capable. So I've mentioned on one of the earlier slides, there are a couple of conditions that we laid out, and we suggest that if those conditions are met, then harm reduction would potentially be an option worth exploring. We're not suggesting that it ought to be employed far beyond that, especially given that people with eating disorders can recover. So this is quite specific, and I just want to highlight that. I'll pass it over to Callum for a moment just to speak about a couple of resources, recognizing that many people do either suffer from or know people who are diagnosed with eating disorders, and resources are, of course, important.
Here are some regional services. So these services are mostly hospital-based, mostly available to all residents of Ontario. So there are inpatient and day treatment programs both at Toronto General, also Credit Valley, North York General has a day program. And there are also programs that are designed for working with child and adolescents. So Sick Kids, South Lake, and Ontario Shores have child and adolescent programs. And then on the next slide, we have resources. NEDIC is the National Eating Disorder Information Center. It's a website that has a call center, a broad range of information about services for individuals and families, also individual healthcare practitioners. So it's a good place to look for resources nationally. Also, FEAST represents Families Empowered in Supporting Treatment of Eating Disorders. It's an international organization that has local chapters, and this supports caregivers of people who have eating disorders and provides information and support for caregivers.
Thank you. So I'll pause here and just thank everyone for listening, and we'll open it up to and are very interested in hearing any questions, any thoughts that you may have about this topic.
Wonderful. Thank you both so much for that insightful presentation. That was absolutely informative and excellent. So as Andrea said, we can move into our question and discussion period. If you haven't already, you can ask a question or a comment in the YouTube chat, but to do that, you also must be signed in. So if you're unsure of how to do that or unable to access the chat, I'd invite you to send an email to Lori from the JCB. Lori's email can be found in the pinned comment at the top of the chat box in the YouTube chat. And as a preface to the discussion, in the instance that we can't get to all the questions, we'll forward them to our speakers. So we only have a limited amount of time, so let's dive into the discussion, just referencing our chat here. So our first question comes from Bob Park. To what extent do you see trauma as contributing to eating disorders?
I would say a large extent. So obviously, not 100% of people who develop severe eating disorders have a history of trauma, but a very significant number do. Now, I would say I probably come from a very biased lens. I have treated people in a tertiary care center. So many people who have developed an eating disorder to the extent that they required tertiary care, such as inpatient or day hospital care, tend to have comorbidities, and trauma tends to be one significant comorbidity. So if we look at the risk factors that was on one of the previous slides, childhood adverse events, including childhood sexual abuse, physical abuse, these have big impacts on attachment, on feelings of trust, on one's sense of self-efficacy, and also on one's sense of one's body. So oftentimes we see people who have maybe suffered sexual trauma, who then develop a relationship with their body where they want to starve away any kind of secondary sexual characteristics or starve away any memories or emotions related to trauma. So this is also a complex question because, again, when we're talking about treatment, what do you treat first, right? So you have to be able to address the trauma to some extent when you are providing treatment for an eating disorder, because again, memories, thoughts, feelings come full force when one's brain is being refed. So you want to provide people with also coping strategies and treatment for trauma in conjunction with an eating disorder. So I think definitely it has a big implication in terms of a predisposing or perpetuating or predisposing or risk factor, and also has implications for treatment.
Wonderful, thank you, Callum. Our second question comes from Rebecca Shalansky, who asks, why is there more stigma around harm reduction with eating disorders compared to with addictions? With this side note, when addictions also take a large physical toll?
A very good question, Rebecca, and I'm curious, Callum, as to whether you have thoughts about this as well. So part of me truly doesn't know. Part of me wonders if it's because of an idea that all people with eating disorders can always achieve complete recovery, and another incorrect idea about people who use drugs. I don't know. It's a very good question, but I think that part of the reason as to why Callum and Catherine and I started working on this is because we think it's important, because people with severe and enduring anorexia nervosa could potentially achieve significant benefit if clinicians are at times at least willing to open up a discussion to exploring whether harm reduction could be beneficial. So as mentioned, I mean, if a person is unwilling or unable to adhere to certain eating disorder program requirements, for example, and if they've had negative experiences working with healthcare providers, then their options are incredibly limited. It's possible they may not be treated at all, and then they won't be able to have a good quality of life with an eating disorder. If clinicians were to practice in a way that, I think, Callum, you can speak to this, of course, but does or is willing to do, then it's very possible that people with severe and enduring anorexia nervosa can attain benefit. They might get access to really beneficial resources. They can maintain their eating disorder, but still have a life that has meaning and that is of good quality according to them. So part of me just wonders if it's just because of a lot of misinformation and incorrect assumptions about eating disorders versus people who use substances. I'm not sure. Callum, do you have anything to add? It's a very good question.
Well, I think we don't really know if one is more stigmatized than the other. I don't think that we have studies to show us that one group would be more stigmatized in terms of looking at a harm reduction approach. Certainly, we hear a lot more about harm reduction approaches when it comes to addiction, because we hear about the injection sites, and we hear about, and that's controversial too, right? The reason we hear about it in the news is because it's a controversial treatment. I guess when it comes to eating disorders, you might consider that intensive treatment resources can be scarce. And so if we're looking at allocation of resources as well, that might be controversial. If there's only a certain number of beds in a certain number of centers to treat this in Canada, and we know that many people can recover, what percentage of those beds do we allow or dedicate to helping people recover? And what proportion of those beds do we dedicate to helping people with a harm reduction approach? I think that might be more the controversial piece rather than looking at stigma.
Wonderful, thank you both. I think we have time for one or two more questions. So Zoe asks, addiction research has shown those who accessed harm reduction programs were more likely to later seek comprehensive treatment. Has your research found this might be an outcome for SEAN patients too?
I don't think that there is research that shows that. I think that this would be a very under-researched area. Also, we have to consider that when someone is at that point, they may be looking at having had decades of illness and having had many episodes of treatment where they tried to have treatment for recovery and it didn't work for them. So it might, any kind of, I think speaking to this would be anecdotal. I don't think it would be research-based, but you would consider the duration of illness and the number of treatment episodes one would have already gone through to get to this place where they're considered harm reduction to be a factor in looking at whether they would consider other types of further treatment after a harm reduction type of a intervention.
And just to build on that, so I agree, I certainly haven't seen any research to support it, but one of the things that we certainly mentioned and have thought a little bit about is that if a person, and I can't recall on which slide who said what, but one of the slides just mentioning that if a person with SEAN were provided with the opportunity to at least achieve, to gain some respite. So if they could be admitted to an eating disorder unit, let's say for a short period of time in order to have their, for weight restoration, let's say, and perhaps during that hospitalization, it's possible that they could be provided with substantial resources. Perhaps speaking to Bob's initial question, especially if you use a trauma-informed approach to care, perhaps some of the other challenges that they may be experiencing or some of the stress that they may be experiencing, perhaps they could also achieve some resources or support in relation to that. So while I think that this is an under-researched area, it is at least perhaps the case that allowing for hospitalization or allowing for some respite, it could enable people to achieve some benefit and access to resources and maybe be more willing to achieve treatment. But again, that's not researched.
Wonderful, thank you both. And thank you to everybody for your questions and discussion. Unfortunately, it is time to draw today's seminar to a close. So unfortunately, we won't be able to address all the questions. But before we end off, I just have a couple of announcements to make before we thank our speakers. Our next seminar will be on Wednesday, February 10th. Daniel Sperling will be discussing, is medical assistance in dying tourism a moral phenomenon? Additionally, to sign up to receive our weekly seminar reminder emails, please email jcb.info@utoronto.ca. CSB students enrolled in the CSB Student Seminar course, please remember to track your attendance. And finally, Andrea and Callum, on behalf of all of us, thank you very much for your presentation.